So I think what we're going to do is welcome everyone to our Lynch Surveillance Hub webinar this afternoon. We're going to start on time so that we don't delay anybody at the end. We are recording the session, so I can't quite see that recording start yet, Emma, but we are recording it so that it can be accessed later by anyone who wants to have a look at it, and we may be repeat running this webinar in a bit at a different time so that more people can have access to it. Okay, so in terms of general housekeeping, we're hosting this in terms of the Cancer Alliance, North Central London Cancer Alliance, and you'll be able to see the recording on our YouTube channel, and Emma or Catherine will pop that link into the chat at some time during the meeting. If you can post your questions in the chat box then through the session, then I'll either bring you in to speak your question or bring it in, share the question myself for everybody at a later point in the meeting, dependent on what the subject matter is. And then afterwards, we've got a quick survey at the end of the webinar. Have a look at that link, which we'll also post, and we'd really appreciate it if you can complete that at some stage. So I think what I'd like to just move straight through to is just introducing everybody on the webinar today. So if I could introduce both Dr. Rosa Vega and Professor Adam Rosenthal, who both from UCLH, who are leading this work for us, and perhaps both of you could give a little pen pal intro about the work that you do, so that our colleagues on the call can understand a little bit more about your particular interests. Thank you so much.
Thank you very much. I'll start just giving a very brief introduction. So I'm a consultant gastroenterologist at UCLH, and I am interested in early cancer diagnosis and early cancer treatment. So I look after patients from the bowel cancer screening program that have early non-invasive cancer and treat them. And because of this line of work, I became very interested on inherited cancer diseases and set up a clinic of Lynch syndrome a few years ago. And that's the reason why I've been very excited to lead on this work together with Adam to make a difference on patients with an.
Thank you.
Adam, over to you.
Thanks, Rosa. So hi, I'm Adam Rosenthal. I'm a consultant gynecologist and prof at UCL. I'm essentially a cancer prevention surgeon, and my main interests are in the HPV-associated cancers. So I lead the colposcopy service here, also look after women with multizonal anogenital neoplasia due to HPV infecting other areas of their anatomy. And then my other key interest, which is very long-standing now, is in women with an inherited predisposition to cancer. That would primarily historically be the BRCA1 and BRCA2 carriers, but now more moderate penetrant genes, and also all of the Lynch syndrome women who we're going to be talking about today. So I do the risk-reducing surgery for these patients, but also arrange their surveillance as well, which was what we're going to be talking about as well today.
Thank you. And then Tom, welcome Tom. Could you say a little bit about yourself? That would be great. Thank you.
So I'm the Senior Manager for the Bowel Cancer Screening Centre, and along with the Bowel Cancer Screening Programme, we are managing the surveillance for colonoscopies in the Lynch population.
Thank you, thanks. And we've also got some of the team as well on the call from the Alliance, Catherine Nestor and Emma Boyle. So thanks both of you for helping us with this. Great. So Rosa, we're going to move to you first of all to kick us off. Thank you very much. I think Emma, you're going to share the slides.
I think Emma, yes, Emma is going to share the slides, and while she's getting them up to speed, I just want to apologize for the croaky voice. Had a bit of a rough weekend, and that's the consequence. Right. So I just wanted to give you a bit of an overview of why we have decided to do this piece of work with Adam for the patients with Lynch syndrome within NCL, and explain a bit the structure of the hub that we have set up. How did we reach there, and how are we planning to evolve, thankfully. So next slide for me, Emma, please. So Lynch syndrome, although it has become a word that is more common in the medical language, it has been for a very long time among us, and affects about 1 in 350 and 1 in 400 individuals. So it is really prevalent. And in the UK, there are between 200,000 and 300 that are likely to have Lynch syndrome, but only 5% of them have been diagnosed. So we are only looking after and surveying probably the tip of the iceberg for these patients. There are usually 1,200 and between 1,200 and 1,300 cancers annually that are related to Lynch syndrome. And it was very evident during the COVID pandemic that these patients had a very different and very heterogeneous way of being looked after. And when we had to, especially in endoscopy units for the colorectal cancer screening, had to reduce the volume that we were doing during the pandemic, these patients suffer massively, and with delays of their surveillance and not having other alternative surveillance ways of colorectal cancer that were as effective as the colonoscopies. So next slide. So in parallel with all these worries that people that we are interested with Lynch syndrome faced, NHS England, together with the Genomic Medicine Service Alliance, set up goals for these patients, where they wanted to transform from diagnosing cancer to diagnose Lynch syndrome. And they set up 4 very specific goals. The first one was to do a bit of a workforce transformation by training people interested in Lynch syndrome and people looking after patients in the colorectal cancer MDTs in terms of this condition. Then they also set up a goal of diagnostic pathways and see how we could improve the percentage of patients that were diagnosed of Lynch syndrome through their colorectal cancer diagnosis. And then the mainstreaming was set up, where when patients were diagnosed of colorectal cancer, independent of their age, they were having tumor testing for the variants that could link to Lynch syndrome, with the hope that that would increase the pickup. Then it was clear that these patients needed to be treated and seen in expert centers in a multidisciplinary matter, and probably setting up regional hubs would be the way forward. And that would also improve the national registry project, because despite the massive effort of trying to capture all the Lynch syndrome patients nationwide, there is not a very structured national registry that we can capture them. So next slide, please. So within NCL, very good work had already been taken place. So the cancer MDT audits that were done through this initiative from NHS England showed that we were doing reasonably well with the tumor immunohistochemistry testing. So that was a very nice green tick. And then within NCL, every trust that had a colorectal cancer MDT identified a Lynch syndrome champion that would look after patients with colorectal cancer, would look after the mainstreaming of immunochemistry through the tumor testing and make sure that happens, and would refer the patient to the genetic services if the immunohistochemistry was showing the possibility of that patient suffering of Lynch syndrome. So all that was happening very well, but unfortunately, next slide, please. The journey that the patients with the journey that the patients were having with in the diagnosis was quite daunting. So first of all, patients were being referred to the genetic services for the counselling and for the genetic testing. Then once they had the Lynch syndrome confirmed, they were given a very comprehensive letter explaining what needed to happen, and probably the GPs were receiving a copy of these letters where they had to attend different hospitals for the different types of screening. The way the screenings were happening were very heterogeneous, as I mentioned, and also patients had to attend maybe different hospitals. The gynecology was happening maybe at UCLH, whereas the colonoscopy in North Middlesex in their unit, and there was not a cohesive plan of care for these patients. Through all that, the patients were having duplications of tests. They were maybe not attending appointments because they couldn't understand very well what the whole structure of it was. And we were also losing patients in terms of opportunity of new treatments and tests because they were not treated in specific Lynch hubs. Next slide, please. So then we have been very fortunate that through the North Central Cancer Alliance, we managed to get the help and the commitment of trying to improve what we did for these patients. So what we have been doing a working group together for several months, and we identified that there was a need for Lynch syndrome patients to have a hub within NCL that we can sort of a streamline their patient journey. We got support from all the NCL colorectal tumor working group that UCLH probably would be the geographical place where the hub could sit, and Adam and myself put ourselves forward as willing to set up this hub and make it happen. Then a business case was approved for a pilot service of a year so far to make sure that what we are providing to our patients makes sense and we can make it profitable from the point of view of seeing patients in clinic and demonstrating we are making a sense. And then we set up the Lynch syndrome self, and we did some staff appointments with a full-time clinical nurse specialist, and Adam and myself as gastroenterologists and gynecology leads, and basically the hub launched on the 1st of September this year, so a few weeks ago. Next slide, please. So what do we do within the hub? So the current number of patients that we had already, even before the hub started, and the colorectal service, because of my individual interest, I was already looking after 150 patients, and Adam in his familial clinic, probably an average of 40 patients. And through the bowel cancer screening that is taking on the surveillance of the colon of these patients, we knew that another 250 patients were going to come through our books in the next 2 years. So, and also we identified that new patients would come through the mainstreaming from the different MDT cancers happening within the NCL colorectal cancer services. So who is running the hub at the moment is myself, as I mentioned, and Adam from the colorectal and gynecological point of view. We have Helen Faransis, that is our clinical nurse specialist, and then we have Cherise and Gemma that from the bowel cancer screening program have taken on the administration support. Next slide. And just to give a bit of and because this slide is very busy, I'm just going to break it down. So next slide for me, Emma. I'm going to explain so far where these patients are coming from. So they are coming from, as I said, the bowel cancer screening program, because patients diagnosed with Lynch syndrome that are within NCL area are going to be invited at UCLH cancer screening hub. They are also coming from colorectal cancer MDTs once they have had their immunohistochemistry tumor testing and their mainstreaming clinics and referrals to genetics for us to offer the overall surveillance pathway for them. They come directly from the genetic services. Perhaps they are first-degree relatives that have gone to the genetic services to have their testing and they tested positive, and also from other clinics, maybe dermatological clinics or urologic clinics, that they have patients with cancer, that they have Lynch syndrome, and they would like to take advantage of this hub. And we will, and once they are identified, they are being registered into the hub and being looked after in the Lynch syndrome service. And what do we do for them? So next slide. So from the colorectal cancer point of view, they will see a screening point of view, they will be seen in clinic at least once with a comprehensive consultation to make sure that they understood the diagnosis, make sure that they understood the importance of the first-degree relatives to be screened, because from previous experience that is not always clear, and we lose diagnosis on the way because of the lack of engagement of first-degree relatives. We do some testing for them from other preventive malignancy link conditions like Helicobacter pylori. We counsel them in terms of looking for the alarming symptoms that they should be raising with us. And then we also counsel them for colonoscopies, which is very important because you need to understand that the screening on those patients starts between the age of 25 and 35, and they will have probably a total of 25 colonoscopies on their lifetime. So we need to ensure that they don't find it unpleasant, that they engage with it, and that we can put in their hands everything they need to feel supported. And then from the gynecological point of view, I'm not going to extend because Adam will explain what he does in his next talk. Next slide, please. So far, we have set up the weekly clinics. We also attend the colorectal cancer MDTs in order to help with the mainstreaming. We attend the regional virtually hereditary MDT, that is an MDT that is set up by the genetic services within London, where we can discuss any genetic results that don't make much sense to us and get help and support when we give the diagnosis to the patients. The colorectal, the Lynch syndrome CNS attends the monthly gynecological regional MDT. We have set up a Lynch syndrome database to capture these patients, make sure through this database we can capture when they need to be nectar-based, that they are taking the chemo that they need, that the first dose, and we don't miss patients in between. And we are providing also support outside the clinic consultations through a patient helpline and email that is being looked after by the Lynch syndrome CNS, where patients, if they are concerned either about colorectal cancer symptoms, gynecological symptoms, or other cancers that are less prevalent but are still significant, like dermatological cancers or urological cancers, they can send us an email and we can help them in terms of any investigations or pathways that are needed. And obviously, we are also liaising with the bowel cancer screening program team in order to help with any Lynch syndrome patients that are put through the bowel cancer screening program and bring them to their hub if they are not having an overall package of care for their Lynch syndrome and they wish to move to our hub. Next slide. So obviously it's a very new setup. There are not many hubs like this within the UK. Maybe few hubs, but only a few Lynch syndrome clinics more but not so cohesive as Adam and I we have in sense of having two different specialties trying to work together. So we will probably be reshaping as we get along and we understand the needs that we to provide for these patients. But the next steps for us, once we are comfortable with the feet that we have on the ground, is to establish links with the NCL Lynch Syndrome champions in every hospital in NCL, so the patients can start coming with much straightforward pathways than going maybe through GPs and so forth, so that we can cut the steps of referrals and not miss patients in between. We would like to establish links and set up bi-directional referral pathways and maybe research interests with dermatology and urology within NCL, because these are also specialties that see patients with Lynch syndrome. And we would like to also set up a quality improvement measurable or demonstrate that this hub is something worth it for our patients, and hopefully establish multidisciplinary collaboration regarding research moving forward. And that's everything from me. Thank you.
That's lovely. Thank you very much. So what I thought would be best that we hear Adam talk to us, and then we'll go to questions. I put in the Q&A in the tab chat stream just a signpost to our Q&A tab for you, which is at the top of your screen. So if we could move to Adam. And Adam, I know that there are some people that have joined us midway through the first talk, so I wonder it'd be worth if you could just give a quick reminder definition of Lynch syndrome and its main challenges.
Sure.
That would be really helpful for the people.
Can you hear me and see the slides okay?
I can. I'm not aware of any concerns with anybody. Please wave anyone if you've got a question.
Because I can only see my slides now, so I'll be talking by. So interrupt me if there's a problem, please. Thanks.
Yeah.
So thanks everyone for joining. For those of you that aren't aware, Lynch syndrome is an autosomal dominant condition. Probably about 1 in 350 of the population have it. It's one of 5 or 6 different mismatch repair gene alterations which increase the risk of specific cancers. The highest risk is colorectal, so that's why you had Rosa talking first, and there's probably about an 80% lifetime risk of developing a colorectal cancer if you have Lynch syndrome. The gynae risk, depending on which gene alteration you carry, can be up to 60% lifetime risk for endometrial cancer and up to 15% lifetime risk for ovarian cancer. But there are other cancers, as Rosa mentioned. There are urological cancers and skin cancers that these patients are more likely to get, unfortunately. So I'm just going to be concentrating now on the gynae side of things. So the rationale for surveillance would be that you could potentially allow women to safely delay a risk-reducing hysterectomy and bilateral salpingo-oophorectomy until their family is complete, and this would give them the advantage of avoiding a premature menopause and the need to take HRT, because we generally offer the surgery from the age of 40, and as you can imagine, not everyone at that age is going to be willing to lose their fertility or their ovarian function. But it's unlike in the colorectal world, where there is a lot of evidence for the benefit of offering surveillance to patients with Lynch syndrome, we don't really have that evidence as such in gynae as yet. We don't really know that surveillance does downstage endometrial and ovarian cancer, in other words, diagnose it at earlier stages than if you wait for symptoms to occur. And if it does do that, does that actually improve the prognosis of the patient, or at least reduce the morbidity? And the last UK statement on this that I'm aware of is one I was involved in a Manchester consensus meeting, and it was basically stated that further research was required to establish the value of gynae cancer surveillance. So that's what we've been looking at UCLH. So in terms of what we offer our patients, we offer the risk-reducing surgery, which would always be, if possible, by the laparoscopic or robotic route as standard of care from the age of 40, or we would consider doing it at younger ages if there are particularly early onset ovarian or endometrial cancers in the woman's family, or if they've already had a premature menopause for another reason. All cases need to be discussed at our monthly MDT to gain approval for surgery, and it's important to note that just because a patient's had a previous colorectal cancer resection doesn't preclude the possibility of us being able to do the surgery via the keyhole route, and all of the advantages that that gives the patient in terms of much swifter recovery and shorter hospital stay. We have access for our patients to our menopause team, who many of you may already have met some of at various points. They offer a really superb menopause service, and we also have a clinical psychologist really for the patients who find it difficult to make up their mind about whether to go for the surgery or when to go for the surgery, and Jenny Van Heerden is our clinical psychologist. So in terms of surveillance, this is what we would offer women who are either too young for the surgery or are not yet ready psychologically to undergo the surgery. So we're offering this now as part of this newly launched hub, working closely with Rosa, and we have our own coordinator, and we share our clinical nurse specialist who has been appointed specifically for this hub with Rosa on the colorectal side. So what we offer the patients as sort of baseline standard would be a transvaginal ultrasound scan and a CA125, along with an annual hysteroscopy and endometrial biopsy. We tend to encourage these to be outpatient procedures because the women are going to need to have these done once a year, and it's quite an effort for them to come in and have a day surgery procedure when it could potentially be done for them as an outpatient. And Professor Ertan Saradogan does our outpatient work for us, but not all women, quite understandably, are willing to have a hysteroscopy when they're awake. We do offer a flexible approach, especially as there isn't really good quality evidence to support the use of these surveillance protocols. So if a patient says, actually, I only want to have the hysteroscopy done once every 2 years because I really find it quite unpleasant, then we're very happy to accommodate that. The main thing, and for those of you on the call who are GPs, the main take-home message for patients and their primary care physicians is that if they get any abnormal vaginal bleeding, however slight, it is really crucial that it's reported to us urgently so that we can arrange an urgent hysteroscopy. And the data I'm about to show you will perhaps emphasize that point for you. In terms of our activity in the last 12 months, and this will presumably increase now that we've launched the hub, we saw 53 outpatient appointment women. We provided 9 risk-reducing surgery procedures. We've got 43 women currently on surveillance. We did 35 hysteroscopies last year, of which just over half were outpatient and little under half were day case under either sedation or, if necessary, general anaesthetic, and 55 transvaginal scans and CA125s. Those numbers are larger than the number of hysteroscopies because we need repeat ones done shortly before risk-reducing surgery, just to make absolutely certain that we're not about to do surgery on a patient who already has a cancer. So this surveillance data I'm now going to present is currently being prepared by our research fellow Malcolm Scott for his PhD and for publication. So we're actually currently analysing 12 years worth of surveillance, which represents just over 100 women who've undergone 400 surveillance years, each of them for a median of 2 years. We've done 284 endometrial biopsies, of which 76 were the first screen and 208 were the subsequent screens or incident screens. And nearly 1 in 5 of these women have actually developed significant pathology whilst they've been on surveillance. We've had 5 cancers, 2 atypical endometrial hyperplasia, which you may be aware is the pre-malignant condition for standard endometrial cancer, 8 endometrial hyperplasias without atypia, which are also a precancerous condition, but at least in the general population can regress without any treatment at all. And certainly the risk of those patients developing cancer is lower than the risk of those who have an atypical hyperplasia. And we've also had 1 ovarian cancer. So I'll deal with the ovarian cancer patient first, as there's just one of her. She actually had a normal screen and then 6 months later came in for a hysteroscopy, which by pure chance was done under ultrasound guidance in theatre, just because it was the practice of the person doing the hysteroscopy and placing the coil to use ultrasound to help them navigate a tricky cervical canal. And by chance they noticed a cyst only 6 months after a previously normal scan. The patient then had a transvaginal scan in the main department the next day, which suggested possibly a borderline or invasive cancer, and he was subsequently been found to be a stage 1C low-grade endometrioid ovarian cancer. So picked up by chance, really, because she happened to have a scan at her hysteroscopy. Now, of course, it may have been picked up at her next annual scan anyway, and whether the stage would have been higher if we'd waited for that next scan before picking it up, we have no way of knowing. Moving on to the endometrial cancers and other diagnoses, on the top right you can just see the difference between a rigid hysteroscope, which is the straight metal one, and then the plastic disposable versoscope, which is what is used in outpatient hysteroscopy, which has a much finer sort of 3mm sheath, which hopefully is more comfortable for the women. So we picked up four prevalent cases, in other words, detected at their first screen, 1 endometrial cancer and 3 simple hyperplasias. All of these subsequently had a hysterectomy, and interestingly, 2 of the 3 actually had worse pathology in their final specimen. And also 1 patient who's not willing to have a hysterectomy, but opted for conservative management with a Mirena, actually went on to develop an endometrial cancer despite the Mirena. And then on the subsequent year's screening, there were 5 incident cases, endometrial cancer 1, atypical hyperplasia 1, and 3 simple hyperplasias. And you can see that one of the simple hyperplasias progressed to atypical hyperplasia despite conservative management with a Mirena. But overall, it does look like 4 women appear to have avoided a cancer diagnosis due to their surveillance, which is obviously a good thing psychologically. We did, however, miss 6 cases. 2 presented symptomatically between their annual screens with unscheduled vaginal bleeding, and 2 of these actually were endometrial cancer. And then there were 4 asymptomatic patients who were diagnosed really as a result of having a hysterectomy within a year of a previous normal screen, or having another test as part of the workup. And this just shows you that interval pathology within a year of a prior normal screen can occur, and the patients in those situations may be symptomatic or asymptomatic. So clearly surveillance is not picking up absolutely everybody. And overall, our sensitivity looking at that data would be only around 60%. The negative predictive value is pretty high though, so if they have got negative results, it's pretty unlikely they're going to be diagnosed with something bad in the next year. But interestingly, the median time elapsed between the last normal screen and them being diagnosed with an interval significant pathology was only 3 months. 4 of the 6 women who were picked up not through surveillance were asymptomatic. But interestingly, all of the endometrial cancers, whether we picked them up or whether they presented with symptoms, were actually the very earliest possible stage, which means that they'd still be expected to be cured by their hysterectomy, irrespective of whether they had screening or whether they presented with symptoms, albeit in relatively small numbers. This is very much in line with the world literature on this subject. So, in conclusion, we felt that endometrial hyperplasia on an endometrial biopsy was strongly associated with worse underlying pathology. So in other words, if you find this kind of histological appearance on a patient with Lynch syndrome, it's much more ominous than if you find it on a patient in the general population who does not have Lynch syndrome. Surveillance does, however, seem to detect precancerous lesions reasonably well, and that's sparing the woman the psychological burden of a cancer diagnosis, even though it does mean she's still going to need a hysterectomy as curative treatment. Despite the successful pre-cancer and early stage cancer detection, our overall sensitivity was only 60%. And all of the missed cancers were stage 1A anyway, so again their treatment wasn't really affected because they would have had a hysterectomy regardless of how they were diagnosed. And these limitations would seem to emphasise the need for novel approaches to diagnoses in order to try and pick everyone up at the point at which they've got a pre-cancer rather than cancer and reduce their morbidity. And finally, we're therefore doing lots of research at the moment to try and improve the lot of women with Lynch syndrome and an increased risk of gynae cancer. And we are about to start doing immunostaining on samples predating the women's diagnosis to see if we could have picked it up by doing different histological tests. And also we've got some novel DNA markers, methylation markers, which we're looking to see if we can detect these on a self-collected swab. So the ideal kind of holy grail for this would be women doing a swab once a year at home and sending it in to us, rather than having to come in for a hysteroscopy once a year. Great, so that's all I was going to say about that, and over to Claire to decide what we're going to discuss next.
Thank you so very much. Thanks. That's really interesting. It's only obviously reasonably recently that people have started talking in primary care in terms of patients coming to see us. People are picking up from the press and other sources and the media in general that Lynch syndrome is something they might need to ask about, but it's still really variable across all our practices, I think. So it's really helpful to hear about this. Now, I've got a couple of questions, but I just want to remind people, put your questions please either in the Q&A ideally, or if you can't access that from the top of your screen, then just pop it into the chat. That's absolutely fine, and I'll pick them up. Tom, was there anything you wanted to add before we just open the full floor to questions from your perspective?
Just that we're relatively new in getting going. I think the first patients came through in July. And in the first few months, I think we've had 35 come through, and the first are now starting to have colonoscopy. And so it's this sort of group we're getting to know, really. But as Rosa intimated, I think it will grow quite quickly. Yeah. Okay. So a couple of questions. The first one is, not all patients worry about this, but a certain proportion do. It is having genetic results or risks of genetic pathology because of gene diagnosis on their records when it's related to other family members, and worrying about whether that affects insurances and that sort of a thing. Do you can you tell me whether there's any provision to safeguard patients from insurance companies or banks using, when they're applying for mortgages, using this sort of data in a way that would be negative to them?
Yeah, I can answer that. I mean, for as long as I've been working in this area, which is probably over 20 years now, there's been a moratorium that the English government has with the insurance companies, which has always been renewed every few years, and I've not heard any rumours that it's not about to be. But what that states essentially, as I understand it, is that if you're taking out a policy up to £500,000, be it life insurance or mortgage or whatever, then the insurance companies are not allowed to ask you about genetic testing results. They may, of course, use your family history as a surrogate, unfortunately, if you do have extensive family history, or if you yourself have already had a colorectal or an endometrial cancer, then that clearly is going to influence things, but they are not meant to be able to ask it. Now, of course, if you're living in London, quite a lot of people would have a policy for more than £500,000. So it's probably about time people started looking at raising the bar, seeing as how much the cost of living has increased since this moratorium was first introduced. But you might be better off asking a clinical geneticist for more up-to-date information on that than me. Right.
Okay. Rose, have you got anything to add on that at all?
No, I was just going to say exactly what Adam said, is what we know so far, but the geneticists are the ones that have a more up-to-date, yeah, so that's it.
Okay, all right, okay. In your own practice, Adam, and in terms of what patients are feeding back to you and your own colleagues, do you find do you feel that the system is well versed and understands the issues around Lynch, or is it new to lots of clinicians as well as lots of patients from a sort of everyday perspective?
Well, I think it is new, because really we've not had an Angelina Jolie with Lynch syndrome. I mean, everyone's heard of BRCA1 and BRCA2 because of Angelina. What we really need is someone really famous to get Lynch syndrome and publicise it, because it's actually as common in the general public as
Yes.
BRCA1 and BRCA2, about, you know, give or take 1 in 300 to 400. I mean, unless you're of Ashkenazi Jewish heritage and have a 1 in 40 risk of BRCA, the UK population risk for BRCA is the same order of magnitude as Lynch. So not many clinicians have heard about it, not many patients have heard about it, but because of this wonderful thing we have now of mainstreaming, where all of the colorectal and endometrial cancers will get tested with the immunohistochemistry to see if it's likely a patient carries a gene alteration, and if it's possible that they do carry gene alteration, they then get through to the genetic testing, the DNA testing point to see if they carry a germline mutation that could be prevalent in their family as well as them. This is all now becoming more critical, and if I'm being honest, one of the driving forces to this has been the therapeutics, because there are now targeted agents which will improve prognosis, not just in BRCA but in Lynch syndrome, with patients who carry germline mutations. So actually the patients with cancer are living longer, because when you know they've got their gene alteration, you can change what the therapy that they get is, and they will do better. So there's a lot of pressure from that point of view. But there's also the other key thing is the idea of cascade testing, which is once you've identified a woman or a man with cancer, where that cancer is found to be due to an inherited predisposition, then it becomes easier and quicker to test the relatives to see if they carry it. And of course, it's 50-50 that a first degree relative of the patient with cancer is going to carry the same autosomal dominantly inherited predisposition. And it's massively cost effective for the health service when you do this, because it's so much cheaper to prevent cancer than it is to treat it. And it's actually probably got to a point now where population level testing is cost effective for these genetic cancer predisposition syndromes. The issue is more how society catches up with the science and how we handle this information, because the insurance thing is going to become a much bigger issue when there are more and more patients known to carry a predisposition to cancer. And we have to be very careful, I think, as a society, as to how we handle this information, because it's in everyone's best interests, because it's in the patient's interests and it's in the health services interest to save money, to know who's at risk, because there are things we can do, be it surveillance for colorectal, risk-reducing surgery for gynae, that will prevent patients getting very expensive to treat cancers. They will remain productive members of society, paying their taxes for longer. You know, it's in everyone's best interest to stop these patients getting cancer. But how we handle that as a society, I think, is the really interesting question. The science is well ahead of where we as human beings are at dealing with this issue. And it's true of cardiovascular and dementia as well. We are in this new era of genomic medicine. Yeah,
no, I certainly in patients that I see, there's a real range of knowledge, but in those people that are aware, they're really anxious about having something on their or they can be anxious about having something on their record, and that may or may not affect how they comply with testing or cascade testing. Even when you're doing the cascade testing, what happens when you come to a point if you in terms of at which point do you communicate with primary care about that?
Rosa, do you want to answer the?
Yes. So obviously the cascade testing will happen with the genetic services. So in the hub, what we will do is try to counsel them for them to be engaged, but the cascade testing will be still within the genetic services. So they will obviously communicate with the primary care all the results, and a copy of their results also comes to us, and then we see the patients and counsel them again with these results. This is from the cascade testing point of view. The patients that are mainstream already diagnosed of colorectal cancer, we organize the testing and then we inform them and correspond to the primary, send all the communications to the primary care. But if I can make an example of when the question you said to Adam just earlier, Claire, and just to illustrate it with an example that is actually the individual I saw in clinic yesterday, just to see where we are and the importance of the hub. So yesterday, through the bowel cancer screening program, I screened a patient with Lynch syndrome. That this patient, she had endometrial cancer treated 5 years ago and was diagnosed of having Lynch. So had a hysterectomy, was doing very well, and through the Lynch syndrome diagnosis that was in the genetic services database, she was identified, received a letter, and came to us. Obviously, I saw her for the very first time in the endoscopy suite, and her last colonoscopy having a type of mutation as an NPA2 that carries quite a significant.
Rosa, I can't.
Her last 45 years ago.
Can you hear me,
So
Rosa?
rather than going into surveillance every 2 years, she had one colonoscopy 5 years ago in her local hospital. She didn't. Yes. Now I can hear you. Yes.
Okay, sorry, there's a delay.
Can everybody hear me?
I think I certainly lost you. I don't know whether the others did for a bit. No. Okay. A bit. Okay. So anyway, that's fine. So with this patient, then what happened?
Yes. So what happened was her last colonoscopy before this one was 5 years ago. So the 2 yearly colonoscopies had never happened, and she didn't understand exactly the reason for that. Also, when I asked about the cascade testing, she had 9 siblings. Communicated the diagnosis to one of the siblings because she's not in touch with the other 8. So there is a potential loss of diagnosis here, and you can see that the patients don't have a full education of what Lynch syndrome really means. Her understanding was that because she had endometrial cancer, in her case, Lynch syndrome only affects the endometrium, therefore she shouldn't be working because this is the type of cancer she's going to look. So these are the type issues that we are having with the patients in the hub that are making you more aware that the hub is really needed.
Yes, no, absolutely. Thank you. What about if we move to kind of what can we do for you in primary care? What things should ideally we be thinking about? How in practice do we signpost people to you if they and how do we what should we do if we become aware that in a cascading program for a particular patient there's been lack of compliance, then a change in wish to be involved or to be tested? What's the easiest way and most appropriate way for us to get people back into the system? Rosa, I'm worried about your pickup, so I don't know whether we could. Adam, if you can't always hear, perhaps if you could let me know, because I'm just worried about everybody being able to hear Rosa completely, and I might ask you to answer. Try Rosa and see how we go, but the pickup's not
Rosa,
ideal.
if you turn your camera off, maybe it'll help.
Yes, let me just turn the camera off. Can you hear me better now?
I think so. It's better. Yes, thanks.
Yes, fine, perfect. Thank you. Sorry about that. I think there are important things. Obviously, we have our Lynch email that we will correspond with primary care for the GPs to have that. And please feel free with any queries that you have regarding patients. We would be super happy to answer them. Have patients coming to your primary care with a diagnosis of Lynch syndrome that not overall looked after in terms of their surveillance. They are not on chemoprevention. It feels that they are over the place, attending different places for different appointments and so forth. We are more than happy to take on board and coordinate all that for them. From the clinical point of view, despite patients, as Adam said, having their surveillance colonoscopies and hysteroscopies on time, we know that the surveillance we offer is not ideal, and there are missed interval cancers in between surveillance. So if they come to you raising any alarming symptoms of change of bowel habit or bleeding or vaginal bleeding, always please refer them to us or encourage them to contact us through the helpline. That would be super useful, because as we've seen from Adam's presentation, there are internal cancers that happen, and also colorectal post-colonoscopy colorectal cancers are very frequent. And what else I wanted to say? And also bear in mind that it's not only endometrial and colorectal cancer. They are the most prevalent types of cancers, but patients can get urological cancers and dermatological cancers. So any patient with Lynch syndrome that comes with any moles that have changed, that they are not certain about them, or patients that come complaining of hematuria, please be aware that they can also develop cancers at much younger age because of the Lynch syndrome diagnosis. And then we are always with very open doors to try to help these patients, either through referrals, if you think that helps, through two-week wait cancer referrals, or contacting us through the helpline email address that we will circulate. We will make sure that James or Tom can circulate with you, so you have it available.
Yeah, Tom, if you have access, perhaps you can put it in the chat. Sorry, Adam.
I was just going to say, I just add that I'm very happy to have a personal nhs.net email from a primary care colleague if they have any questions. And I think the bottom line, just to emphasise what Rosa said, is that the red flag symptoms are the same as they are in the general public, but the difference is that it can happen at pretty much any age. I mean, there are people in their 20s developing bowel cancer and endometrial cancer with Lynch syndrome. It does happen. So remember your red flags, ignore the age, and just think, if this is Lynch syndrome, if this symptom is a red flag, I don't care if they're 25, I'm still going to send them in on a 2-week wait pathway.
Yes.
And if you get gypped for that, then come straight back to me or Rosa, because we'll make sure it happens, because we do occasionally get really early onset cancers in this population.
That's an important message. Thank you very much. Anybody want to wave their hands and ask a question if you don't want to put it in the chat? Anything that people have worried about? I think people seem to be okay so far. Are there areas, Adam, that we haven't, or questions I haven't asked you that you would have expected me to ask, so that we can just share the answers with everybody?
Not off the top of my head, no. I think we've had a pretty comprehensive discussion about it, really. I guess I'd just simply say that we will undoubtedly be writing to some of the GPs in our patch when the patients take part in research, and we would just encourage them to encourage this very well motivated group of patients and help facilitate research. I mean, it wouldn't be anything we would expect primary care to have to devote a significant amount of time to, but the idea of, for instance, being able to do self-collected swabs. Some of you may well have had patients on the UScreen study, and that will be publishing pretty soon, as I understand it.
Yes.
So this is, I think, the future of cancer screening in women, at least, is going to be self-collected swabs, but we're not there yet. And UCLH is one of the world leaders in research in this area, so we would really like to make sure that our patients still keep participating in the research, because it'll improve a lot of their daughters going forward, so they're very motivated to help out.
Okay, well, absolutely. Anything else for anybody? I'm mindful that we've got about 5 minutes to go. So just as a reminder, because you talked about younger people, or was that somebody about to say something? Just heard
yes,
a noise
Claire,
there.
it's me, Rosa.
Rosa, hi. Sorry, I couldn't see your hand.
No, it's me. Just very quickly, in terms of primary care, most of the times when we see the patients, will our correspondence and see that we have tested the patients for Helicobacter pylori because it's a precancerous predisposition, and it's important to exclude it in patients with Lynch syndrome. Sometimes patients, if we set up a telephone consultation, they find it more comfortable and convenient to come to the primary care for that. So we may be asking our colleague GPs to facilitate this testing for us.
Right.
Also, just to mention that as chemoprevention, 150 milligrams of aspirin reduce the risk of colorectal cancer in 6 out of 100 patients with Lynch syndrome. So unless there is a contraindication, we are going to prescribe aspirin for them as well long term. And obviously that would be fantastic. And if patients complain of intolerance, communicate with us if they haven't done it through the helpline, and that would be also a very.
And what do you do if patients
the care of these patients?
Right, Rosa, if patients she can't hear me, I don't think. Rosa, can you hear me?
Yes.
Yeah, if people complain of intolerance of aspirin, what's your next line of approach? Just so that we know, because I think we just need to be clear, and we'll send something out around it. If it's a short answer, we could share it now, or otherwise we'll send something out to everybody following this.
It's a short answer. So if they cannot tolerate 150 milligrams, the advice would be to reduce it to 75 milligrams. And if they still have some dyspepsia, then the advice would be to try to take it with any PAM proton inhibitor and see if that helps. If not, then we will stop the chemoprevention for those patients. And on that note, any patients with anticoagulation, then aspirin is not really indicated unless the risk for anticoagulation is very, very low, and the risk of cancer keeps more the balance of taking aspirin, but we wouldn't just take anticoagulation and ask the chemoprevention point.
Okay, and can I ask Tom, in terms, if people want to have a query about a person that's been offered some treatment via the hub, either intolerance or something else, I mean, obviously, what's really helpful for primary care is a very quick route back. So what would you prefer as your direct contact mechanism to clarify something around that if a GP had a question?
So they could come to that generic email would get through to me, I'm sure, the same day. But I'm very happy to people to email me direct. Shall I type my own email in the?
Yep, that's fine. As long as that's really helpful so that people can be clear about that. Yeah, and Adam's already kindly said he's very happy to be contacted on his email. So I think it'd be helpful, Adam, if you put yours in the chat as well, even though it is possible sometimes if you've got your team setting correct to see people's emails. But if you could put it in that chat, that would be great. Okay, so we've come to the end of our hour. I think this is the beginning, clearly, of a whole new suite of tests and provisions of care, prevention of pathologies in the cancer space that we're all meeting and have been meeting over past months. We're really pleased to see, from an alliance perspective, the programs that are initiating in our geographical NCL patch. But I'd be really keen to have any feedback. We've got an option of you to be able to feedback in the if you have a look in our chat area, you can feedback any other questions you have. We will go, if you've got questions or questions occur to you in the next day or two, if you add them to the chat, we will pick them up and then include them in something when we kind of come out with a sort of advisory, any advisory notes. As I said, we'll probably be doing this, I'm sure, this same webinar again. This current one will be available on our YouTube channel, but we'll do some follow-up ones because it's the beginning of a whole new chapter of genomics, medicine and cancer, I think, for us. So thank you, the three of you, Adam, to Rosa, to Tom, for coming today, and thanks for our audience, and we'll see you all shortly. Thank you so much.
Thanks.
Thank you.
Bye-bye.
Bye-bye.